Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on your journey to a 250. So this is Neurological Emergencies and Strokes Part 2. So here we have, which of the following best characterizes the type of stroke seen in this patient? A 65-year-old woman with a history of hypertension presents to the emergency department with a sudden onset of severe headache, nausea, and vomiting. On examination, she is found to have a decreased level of consciousness, right-sided hemiparesis, and impaired coordination. Non-contrast CT scan of the head reveals the presence of hyperdense areas within the left basal ganglia. Now, which of the following best describes the type of strokes in this patient? Lacunar stroke, embolic stroke, ischemic stroke, hemorrhagic stroke, or transient ischemic attack. So the sudden onset of severe headache, nausea, and vomiting, decreased level of consciousness, and neurological deficit, along with hyperdense areas on CT scan, is indicative of a hemorrhagic stroke. Now, hemorrhagic stroke results from bleeding within the brain parenchyma or into the surrounding spaces. So the correct answer is the hemorrhagic stroke. Talking about lacunar strokes, which are small localized infarcts typically involving the deep brain structures, are often present with uh, poor motor and sensory deficits. Now, the patient's presentation is more suggestive of hemorrhagic stroke. Talking about embolic stroke, which is a result from the occlusion of the arteries by emboli, causing sudden onset symptoms. Hemorrhagic strokes typically present with a more rapid severe onset compared to ischemic stroke. So ischemic stroke results from the occlusion of blood vessels leading to inadequate blood supply to the brain. And the patient symptoms, including the sudden onset of severe headache and the presence of hyperdense areas on CT, are more consistent with a hemorrhagic stroke. Now, talking about the transient ischemic attack, which are only brief episodes of warning strokes of neurological dysfunction caused by temporary facial ischemia. The patient's persistent and severe symptoms are not typical of a TIA. Now, we have covered the ischemic stroke in the previous video. So ischemic stroke is due to a clot causing embolic stroke or a plaque causing thrombotic stroke. Okay, but when we talk about hemorrhagic stroke, it may be some already from brain aneurysm which has gone into rupture. So the most typical cause for that is the subarachnoid hemorrhage, and there is some other torn artery causing intracellular hemorrhage. So some artery may go into spontaneous toning, okay, some spontaneous break, and it can cause hemorrhagic stroke. So ischemic stroke, a clot breaks blood flow to an area of the brain, and in hemorrhagic stroke, the bleeding occurs inside or around the brain tissues. Now, there are some symptoms which are common in both hemorrhagic stroke and ischemic stroke, which may be sudden weakness or numbness on one side of the body, confusion, headaches, and seizures. But you need to differentiate hemorrhagic or ischemic stroke in your examination, and this is how you do it. In case of ischemic stroke, there is numbness or weakness in the face, arm, or leg, often on one side of the body. There is confusion, trouble speaking, or difficulty understanding speech. There is trouble seeing in one or both eyes, trouble walking, dizziness, loss of balance or coordination, severe tension like headache with no known cause, and nausea and vomitings may occur in some cases. In case of hemorrhagic stroke, a severe headache at the back of the head which could be described as the worst headache of my life. And it is the typical feature of hemorrhagic stroke. Numbness or weakness in the face, arm, or leg, especially on one side of the body, trouble speaking and understanding speech, vision changes, loss of coordination, balance, and loss of consciousness may occur. So the typical worst headache of my life or the thunderclap headache is one differentiating factor from the hemorrhagic stroke, and this hint may be always present in your examination. Now let's do one more question here. Now, which of the following is the most likely cause of the patient's symptoms? A 45-year-old man with a history of untreated hypertension presents to the emergency department with a sudden onset of a severe headache described as the worst headache of his life. The headache began suddenly and is accompanied by nausea and vomiting. On examination, the patient is alert and oriented but reports neck stiffness. Kernick's and Brudzinski sign are positive. Non-contrast CT scan of the head is performed and no abnormalities are noted. Lumbar puncture reveals an elevated opening pressure and xanthochromia in the CSF. Which of the following is the most likely cause of this patient symptoms? Migraine headache, tension type headache, subarachnoid hemorrhage, cluster headache, or sinusitis headache? I'm damn sure that you will be able to answer this question. So, the sudden onset of severe headache, often described as the worst headache of one's life, accompanied by nausea, vomiting, neck stiffness, positive Kernig's and Brzezinski sign, and xanthochromia is the cerebrospinal fluid, is indicative of a subarachnoid hemorrhage. SAS is commonly caused by the rupture of an intracranial aneurysm. So, the correct answer is subarachnoid hemorrhage. uh, you can go through other differentiating other wrong options, okay, which are typically of different types of headaches: migraine headache, tension type headache, and cluster headache or sinusitis headache. We can just pause the video and go through these all. Now, this is the typical computed tomography technique findings, okay, CT findings of subarachnoid hemorrhage. You can see that in normally, this is the normal isotone signal here, isotone signal that is dark gray of CSF fluid in the subarachnoid space. Now, whenever there is subarachnoid hemorrhage, this isotone changes into hyperdense signal that is light gray in the subarachnoid space, which is due to the presence of blood. Okay, so this all is blood. Okay, here. And this is the one typical picture that they will show you in your examination. So you don't need to remember or look at out the other CT findings of the subarachnoid hemorrhage. So, reviewing the first state of your subarachnoid hemorrhage, it is bleeding due to trauma or rupture of the aneurysm or AV malformation, rapid time codes, patient complaint of worst headache of my life, bloody or yellowish anthrochromic lumbar puncture. Vasospasm can occur due to the blood breakdown or rebleed 3 to 10 days after hemorrhage. Ischemic infarct, nimodipine is used to prevent and reduce vasospasm, and there is increased risk of developing, communicating, and obstructive hydrocephalus. So these complications are very, very important to remember from the subarachnoid hemorrhage. Now let's talk about a TCS or thunderclap headache. So whenever the patient complains of thunderclap headache, you need to do a non-contrast head CT scan ASAP. Now, if it's positive for subarachnoid hemorrhage, okay, then we need to consider further evaluation to define other vascular anomalies, and for that we need to do a CT angiography. Okay, now if it is negative for subarachnoid hemorrhage, then we again do CT scan after more than 6 hours. Okay, and again, if it is negative, then we do a lumbar puncture. Okay, now abnormal LP or equivocally abnormal, we go for CT angiography. But if it is negative for subarachnoid hemorrhage and CT scan is done within less than 6 hours, then subarachnoid hemorrhage is ruled out. Okay, consider other causes of TCH. Okay, and if not, we can always go for the CT angiography. Now, so subarachnoid hemorrhage clinical features are sudden severe headache, brief loss of consciousness, meningitis or nausea and vomiting. Diagnosis is through CT scan and lumbar puncture. Okay, now there is some grading score for the subarachnoid hemorrhage, and you can just go through this all. But this I have kept only for your information, but it is not generally tested in the USMLE step 1 examination. Now, talking about the triple S therapy for this sort of diseases. Now, so triple S therapy is a medical treatment used to prevent vasospasm after aneurysmal subarachnoid hemorrhage. Now, you have seen in here that vasospasm can occur. So, to treat the vasospasm, we uh, prefer the triple S therapy, which the triple S means the hypertension, hypervolemia, and hemodilation. So, hypertension in general is to maintain the systemic blood pressure above 150. So some patients will require a higher systemic blood pressure to prevent vasospasm. Okay. So we don't need to be surprised if our parameters are to keep SBP 160 to 180. The hypervolemia, so fluid volume should be optimized, okay, with central venous pressure 8 to 12, and expect the patient to have maintenance fluids running and possibly need fluid boluses now and then. Hemodilution goes hand in hand with hypervolemia to decrease the viscosity and facilitate the blood flow through the cerebral vasculature. Complication. Risk of rebleed, especially in unsecured aneurysm, also surgical clipping is done first. Elevated ICP can occur. Cardiac failure due to the increased workload, myocardial ischemia can occur. Pulmonary edema, electrolyte abnormalities can occur, cerebral edema can occur, and the risk of vasospasm is about 4 to 12 days after the initial hemorrhage. So vigilance and careful neurological assessments are vital in 4 to 12 days after the attack. Now let's do one more question here. So which is the most likely cause of this patient's symptoms? A 70-year-old man with a history of uncontrolled hypertension presents to the emergency department with a sudden onset of severe headache, altered mental status, and right-sided weakness. On examination, the patient is drowsy, disoriented, and has a Glasgow Coma scale of score 10, and there is a right-sided hemiparesis, and the right plantar response is extensor. Non-contrast CT scan of the head reveals hyperdense areas within the left basal ganglia, extending into the adjacent white matter. What is the most likely cause of this patient's symptoms? Ischemic stroke, transient ischemic attack, migraine headache, intracerebral hemorrhage, or subarachnoid hemorrhage. So the sudden onset of severe headache, altered mental status, right-sided weakness, and a non-contrast CT scan revealing hyperdense areas within the left basal ganglia extending into the adjacent white matter are indicative of intracerebral hemorrhage. So we have talked about ischemic stroke. We will talk in a minute about the TIA. We have talked about subarachnoid hemorrhage, and this is about migraine headache, which says that migraine headaches can present with severe headache, but the altered mental status and neurological deficits in this case are more concerning for an intracerebral hemorrhage. So these are the different types of hemorrhages that you can encounter in your clinical practice. So we will just focus on this intraparenchymal hemorrhage, which means that the hemorrhage is inside of the brain. Okay, it is generally due to the high blood pressure, trauma, AV malformation, and tumor. Now the source is arterial or venous, and the shape is typically rounded, and presentation is acute. Okay, now this is the intracerebral hemorrhage. Now, interventricular hemorrhage is when the hemorrhage is inside the ventricles, okay, which can be associated with both intraparenchymal and subarachnoid hemorrhages. So it typically takes the shape to a ventricular sort of shape inside the ventricles, it gets dispersed, okay. Now, talking about the subdural, which is between the dura and arachnoid, is generally due to trauma and to the breathing veins. Epidural is between the dura and the skull, and it is generally to the trauma due in the arteries, okay. Now, intracerebral hemorrhage can be presented in this sort of typical clinical scenario. Okay, you can see there this is the intracerebral hemorrhage here. So, for example, a 55-year-old construction executive comes to you with poorly controlled hypertension and slumps over table at a board meeting. So, due to hypertension, the patient did develop intracerebral hemorrhage, and he arrives at the emergency department 30 minutes after onset with GCS of 9, and BP is highly increased. What do you do in this case? We do your hematoma evacuation, lower the BP to systolic less than 140, and allow the patient to pass away due to poor prognosis. What you would be your approach here? Okay, keep the answer in mind. We will discuss. So uh, now you have known that there are different types of strokes. So there are ischemic strokes, subarachnoid hemorrhage, or subarachnoid hemorrhage, and there are hemorrhagic strokes. If there is intracerebral, okay, if it just involves the brain tissue, we call it intraparenchymal, and if it extends into the ventricle, we call it intraventricular. So intraparenchymal and intraventricular are intracerebral hemorrhages. Now, here we have one more question. So, what is the most likely explanation for the patient's symptoms? A 60-year-old man with a history of hypertension and diabetes presents to the emergency department with a sudden onset of right-sided weakness, slurred speech, and difficulty finding the right words. The symptoms begin abruptly but resolved within an hour. Okay, now this word is very, very important, resolved within an hour. The patient denies any current complaints and reports feeling completely back to normal. What is the most likely explanation for the patient's symptoms? Migraine aura, transient ischemic attacks, complex partial seizure, acute ischemic stroke, or hypoglycemic episode. So the sudden onset of focal neurological deficits that resolve completely within 24 hours is characteristic of a transient ischemic attack. So what are the different causes of transient ischemic attacks? So it may be due to obesity, smoking, heart disease, diabetes, okay, like in our patient, high levels of blood cholesterol, old age, and hypertension. So, talking about the TIA, which is a warning stroke or mini stroke that produces a stroke-like symptoms but no lasting damage, is called the transient ischemic attack. So, it is caused by temporary state of reduced blood flow in a portion of the brain, where this is most frequently caused by tiny blood clots that temporarily occlude a portion of the brain. A primary blood supply to the brain is through two arteries in the neck that branch off within the brain to multiple arteries that supply specific areas of the brain. So thank you for watching. Keep studying hard. That was into the neurology sessions.